Welcome back to Diabetic Foot Files, where we don't just treat wounds, we decode them. I'm Dr. T, and today episode we're going to talk about parasites. So, this is not just about infections, this is about ecosystems, opportunistic parasites, the things that move when no one's looking. So, let's get into it. So, you have to remember, long before antibiotics, before microscopes, before we even understood infections, humans noticed sometimes wounds would have something in them that moved. So, what is a parasite? Because people use that term as like just saying, oh, that person's a parasite, right? But at its core, a parasite is not just an organism. A parasite is a strategy for survival. So the scientific definition of a parasite is an organism that lives on or within a host, deriving nutrients at the host's expense, often causing them harm. I remember when I learned about viruses versus bacteria, I just thought the virus has to be a parasite, right? But that definition is incomplete. So, because parasites are not just feeding, they're invading, they're adapting, and they're manipulating the environment. So, parati- parasitism is one of the three major biological relationships. So, there is mutualism, which is beneficial to both the host and the invader, right? There's commensalism, which is one benefits while the other one is unaffected, not affected at all. And then there's parasitism, parasite, right? Parasitism, okay? And one benefits and then the host is harmed. And in diabetic foot ulcers, they create this perfect ecological niche for parasitism, for parasites. So let's go a little bit about the history because I always love to go a little bit into the history of things. So, where did we get the term parasite? So, it's from the Greek for para. Everybody knows para means beside, and cetos means food. So, if you translate it Greek wise, it's one who eats at another's table. So, that's a good way to remember a parasite. So, Aristotle was one of the first to systematically, really, describe parasites. So he observed worms in animals, noted that some organisms depended entirely on others, but he didn't understand how they formed. And at that time, people believed in spontaneous generations, that organisms just appeared. And then Francisco Redi in 1600, this is where everything changed. He performed a simple but revolutionary experiment. He Meat was left open and then maggots appeared. And then the meat was covered and no maggots appeared. So in conclusion, he made this conclusion that larvae came from flies and not from the wound itself. And this is one of the first scientific explanations of a parasitic infestation in a wound, right? So, what are some of the first recorded cases of this happening in wounds? I mean, in ancient medicine, Egyptian, Greek medical texts, even Roman war records, they would just say worm-filled wounds or living decay. They called it living decay. And then war medicine, this is pre-modern era. Battlefield surgeons observed soldiers with maggots in their wounds. Some wounds worsened, others surprisingly improved. So that was a paradox that we later got to understand better, right? Because remember, we do have maggot therapy that actually is helpful because not all parasitic presence is purely destructive. So, like I said, why are they called parasites? A parasite must meet three conditions. One is dependency. It's not, it cannot complete its life cycle without a host. Two, second part to being a parasite is a nutritional exploitation. It feeds on tissue, blood, and cellular components. Third part of being a parasite is harm to the host. So this is key. If there is no harm to the host, it is not parasitism. So in diabetic foot ulcers, necrotic tissue is a great food source for these parasites. Open wounds is the entry point. Impaired immunity makes it harder for your body to fight off, and there be no resistance. So a parasite in a diabetic foot ulcer doesn't just live there; they actually thrive there, and that's not what we want. So do parasites actually target wounds or do they just find them? So we already did about fly larvae, right? So myiasis. So fly larvae, we already know they're attracted to heat, moisture, and odor. And these chemicals that they produce, the fly larvae produce no, the chemicals that are produced by the necrotic tissue and the bacterial metabolism, the wound is pretty much broadcasting to these parasites that I'm vulnerable, and the parasites respond. So there is a paradox when it comes to parasitism. There's destruction versus healing. So, like we said, in wound care we have controlled sterile maggot therapy, biotherapy. And like we said, we use Lucia serrata. I'm sure I'm not pronouncing that right, but these are the larvae, and it's supposed to consume only necrotic tissue. It helps reduce bacterial load and promote healing. What we see often as well is uncontrolled parasitism secondary to fly larvae, right? Because these things are aggressively invading the patient's tissues, especially it leads to worsening of the ulcer and can damage viable tissue. But it happens usually due to the wound not being covered properly or neglect of the wound or not somebody noticing that the wound dressing is open, things like that, okay? But like I said, it happens quite often, and the big thing that our goal is to make sure that the wound is covered and dressed well enough to not be an environment for a parasite to want to go along their area. And that's why I like iodine, because parasite won't thrive in that area where there's iodine too, okay? So what does that mean for diabetic foot ulcers? Like I said, our diabetic foot ulcer is not just a wound. It's a nutrient field, it's a chemical signal hub, it's an ecological system that goes up in there. So parasites enter if they do enter a diabetic foot ulcer, the tissue is dying, the host defense system is weak, the environment is exposed. So it's not random. They select this environment. So what makes it opportunistic? So these parasites are rarely the primary pathogens, especially if it does infect the diabetic foot ulcer. They are usually secondary invaders, exploiters of the necrotic or the necrosis, and are attracted by biochemicals. So does a diabetic foot ulcer invite some parasites? So we have the neuropathy, right? No pain, causes delayed care. The ischemia and the necrosis causes a nutrient-rich environment for these parasites. The hyperglycemia, which causes our immune dysfunction, makes it harder for our immune system to fight off these parasites. And then an open wound, which is environmental exposure. So the parasite don't create the wound; it usually just capitalizes on the wound. So what are some of the common parasites that happen in diabetic foot ulcers? Like I said, myiasis, the fly larvae, okay, and the pathophysiology of it, like I said, the flies detect the necrotic tissue and they also detect the volatile amines and they deposit eggs into the wounds and then the larva hatches. The larva makes these proteolytic enzymes that digest tissue and then causes mechanical destruction of the tissue as well as enzymatic liquefaction. So the larvae also penetrates deeper layers over time. The life cycle of these fly larvae, I did a whole episode on it. The egg is like 8 to 24 hours. The larvae has 3 stages, which lasts up to 3 to 7 days. And there's something called pupation, and then it goes into the environment. But all these documented cases of diabetic foot ulcers with myiasis had concurrent bacterial infection. I don't think they ever seen mono infection with just parasite alone. Okay, it's usually concurrent with a bacterial infection. Next is cutaneous larvae migrans. Okay, so it's caused by a certain parasite. I am not going to be able to pronounce that for y'all. I am so sorry. Okay, the tongue is tied. Okay, so pathophysiology of cutaneous larvae migrans is the larvae penetrates the epidermis. It cannot. Cutaneous larvae migrans cannot invade deeper. It migrates only superficially and triggers an intense inflammatory response. And the life cycle is it penetrates your skin within hours, and then the migration lasts about days to weeks. And it has a clinical signature, which is these serpiginous tracts, and then it causes pruritus, and a little bit of pain. Sometimes a lot of pain. Now, another parasite is Strongyloides diasis. I'm going to just spell it for you. Strongyloidisas. Okay? This is very rare. Strongyloides. Okay? Strongyloides. This is very rare. The pathophysiology of this, it penetrates the skin, then it gets into the bloodstream, then it gets into the lungs, and then it gets into the GI. It causes this auto-infection cycle, which is quite unique. But in diabetic patients or immunocompromised patients, it causes a hyperinfection syndrome and dissemination to the wounds. Next one that we're very common with is scabies, which is an indirect contributor. But scabies, the role if it affects a diabetic foot ulcer, it's gonna be intense itching and scratching, the skin barrier breaks down, and it could cause a secondary ulcer formation. So how can we do a clinical differentiation between parasitic, bacterial versus fungal? So parasitic, when it comes to movement, right? Parasites do move, like larvae. Bacterial, yeah, they move, but not really. Like we're not seeing it with our own eyes, right? Bacteria, no. Fungal, no. Odor. Parasitic infections are usually putrid, necrotic. Bacterial, I mean, they are still putrid and necrotic as well, but it's purulent. And then fungal are usually like musty and moisture driven. Then pain, parasitic infections in our wounds, often it's minimal because of the neuropathy, because I believe a lot of people would feel it if they had really great protective sensation, or what do they feel like tingling, right? Not like neuropathy tingling, but they could feel like something crawling, right? If they had protective sensation intact. Bacterial pain is usually high with bacterial infections as well as fungal. It varies. Patterns for parasitic infections, like we said, tracts and burrows. Bacterial, you usually see diffuse cellulitis. And our fungal, we see maceration and stellate lesions. And response to antibiotics, if it's a parasite, it's not going to respond to antibiotics well. Remember, but a lot of parasitic infections are co-current with bacterial. So they're most likely going to prescribe antibacterial as well as an anti-parasitic. Okay. I don't like when people try to prescribe antibacterial for virus. That's not how it works. It doesn't make sense, but some people do it for some reason. I don't know why, but that's not the whole purpose of it, and that's a misuse of an antibiotic. But if it's not responding the way it should, you're treating the wrong organism, and that's the whole point of doing a tissue biopsy, a wound culture, things like that. So, what is the gold standard for figuring out if this is a parasite or not? Well, you see with your eyes, direct visualization. So if you see the larvae, you can see that. Then wound exploration, so the depth progression, the tissue destruction patterns. Then microscopy, the identification of, larva stage as well as species identification. And like I said, myiasis, the fly larva in diabetic foot ulcers is rare, but if it happens, it can be quite severe. And then, yes, it's often linked to poor hygiene and necrotic wounds, but this is a whole no judgment zone. That's the whole point of being a doctor. No judgment. What are you judging for? You're supposed to heal, right? So how do we treat this if it's a parasitic infection in a diabetic foot ulcer? So mechanical removal, okay? Medications without removal is failure. So things like, let's say, scabies, ivermectin, right? Ivermectin works well for things like scabies because it binds to the glutamate gated chloride channels, and that causes increased chloride influx, which causes paralysis of the parasite and which will result in death. Albendazole. You'll be surprised. Some developing countries have albendazole over the counter, and it's like less than $5 or $10. But the biochemistry of albendazole, and that's an antiparasitic, right? It inhibits the microtubule formation and blocks glucose uptake because everything thrives on glucose. Okay, so that if it blocks the glucose uptake, there's energy depletion in that results in the parasite death. Per permethrin Permethrin is another antiparasitic. The mechanism is it disrupts the sodium channels and causes neuronal hyperexcitation, which will result in death. So here's the truth that sometimes we miss. Parasites in diabetic foot ulcers, like I said, are almost always polymicrobial. Most diabetic foot ulcers are. So if you see that, it's most likely in co-infection. Okay. So the parasite might also even carry a bacteria. Sometimes parasites actually do spread resistant genes. Now, think about the symbiotic relationship because this is where it can get a little fascinating. The larvae, which breaks down the tissue, can feed on bacteria, and then the bacteria produces odor, which attracts more flies. So it causes even a biological feedback loop. So, how common is it to have a parasitic infection in a diabetic foot ulcer? It's very low, okay? Rare overall, like 15%, okay? But the populations that are higher risk are people higher tropical climates too because, insects love heat, right? Some insects really love heat. Neglected wounds or poor hygiene, okay? But like I said, it's rare but devastating. But like I keep on saying, no judgment zone. Honestly, there's no reason to. And the whole point is to just keep it clean and get the parasite out and treat it. Make sure that it never happens again. Like I said, I'll never get one of my patients that had it, larvae, the maggots, and told the person, "You're never gonna have them again. You're never. This is never gonna happen again," and it never did. Never did. Happy about that. I'm never gonna let your wound have maggots on them again. Yeah, that's good. Yeah. Okay. That's just me missing one of my patients. So, what is the latest research insights, emerging concepts? Parasites as vectors of resistant bacteria, biofilm plus larvae interactions, interest in controlled maggot therapy, okay, in contrast to uncontrolled myiasis, and wound microbiome, okay, because it's called it equals a multi-kingdom ecosystem. So a diabetic foot ulcer is not just a wound, it is a environment. And in every environment, it selects what survives. And if you're only treating the bacteria, you might miss the whole ecosystem. So that's why we're gonna decode the whole diabetic foot ulcer. Sometimes we miss it. But that's the thing that's so fascinating about diabetic ulcers. I told you not one ever is the same. So next time if you see one that doesn't heal, ask yourself, what else is living in there? And this is Diabetic Foot Files. I'm Dr. Chi, and take care of your feet because they take care of you.